The OSCE station that we'll be discussing is female sterilization. Now, this is a very common OSCE station that appears now and then in the MRCOG Part 3. And it is a very common patient that we encounter day in and day out in our gynecological clinics here in the UK. Now you will get candidate instructions, which should be in lines of this. You're an ST5 trainee, so don't get confused regarding which grade of doctor you are assigned to be. It can be a registrar, it can be a doctor, it can be a healthcare person, it can be a trainee, it doesn't matter. Your approach and your what you need to do in the OSCE station remains the same. So you are the ST5 trainee providing counseling on female sterilization to a woman considering this as a form of permanent contraception. You have a patient, Sarah, who is 35 years of age with 2 children and a stable relationship. Your task is to take a relevant history, consider the reasons of sterilization, discuss the procedure, its effectiveness, explain the potential risks, benefits, and the alternatives, and answer any questions that the patient might have. You have 8 minutes for this station. Now, this may seem to you quite exhaustive and quite long, and you may think that you would struggle to complete the entire thing in 8 minutes. But trust me, if you know your script well, if you know your steps and exactly what to answer, 8 minutes is good enough. You'll have the role player who has been given a brief. The background information for this particular station would be in lines like this. Patient's name would be Sarah Johnson. She's 35 years of age. Her family is complete. She has 2 children, aged 8 and 5 years. She's a fit and fine woman with no long-term health issues. She has had 2 vaginal deliveries and has had no complication. She had previously used the oral contraceptive pills and the copper IUD, and currently she's not on any due to the side effects she faced with them. She's not on any regular medications. She's allergic to penicillin, and she has an unremarkable, non-significant family history. The role player will be instructed to ask questions. It's not that she will ask, she might ask, which may include what the procedure involves, its effectiveness, the risks, benefits, side effects. She may have specific questions like, will it worsen her periods? Will it cause period pains? She may want to know alternatives. Now, most of the time, if you have covered all the points, the role player will not ask you these questions. But however, if the role player feels that you have missed out on points which are clearly written in the marking scheme and will disadvantage you, she will ask you the questions. So always remember, the aim of the exam is not to fail you. The aim of the exam is to give you all sorts of opportunities so that you pass and give you a very fair chance. So take a good history. When it is a history taking station, you have to be absolutely bang on. This is a very basic step, a very basic task as a medical professional throughout your entire career, and you're not expected to falter with it. So you need to cover all the points of a standard history taking, including the extra ones that you need for obstetric and gynecological patients. You start with history of current illness or her current complaint, go through her general health, go through obstetric history, gynecological history, medical history, surgical history, go through her allergies, any previous contraceptive use, drug history, and family history, along with history of any addictions. After your history is done, in this case, there's nothing much significant in this patient's history, and she is a fairly straightforward patient. So your history taking should not take more than a minute, or at the most couple of minutes. Now you explain what a sterilization is, how do we do it, and what it entails. Reiterate to the patient that it's a permanent form of contraception. It is done by blocking or sealing the tubes. It can also be done by removing both the tubes. The most commonest procedure that we use in the UK for sterilization is clipping both the tubes using Filshie's clips. Bilateral salpingectomy is also an option because we know that many ovarian cancers actually originate from the fallopian tube, and hence that's an option that you give to the patient as well. However, you need to reiterate that it is a slightly extended surgery, and sometimes in the background of gross adhesions and scarring in the pelvis, clipping of the tube is much more simpler. You explain the methods. Avoid using term laparoscopic surgery because most patients in the UK don't understand the term laparoscopy, but they do understand keyhole surgery. So use the term keyhole surgery. Uh, so describe how we do it. Explain that it's done under general anesthetic. It is a day case procedure that is done in the UK. So you come, you get it done, and you go home after 2 to 3 hours if everything is fine. Instruct the patient about the immediate postoperative period. She will be given local anesthetic at the end of the surgery, which will keep her pain-free over the next many hours. And then she should take simple painkillers in the form of paracetamol plus minus ibuprofen. She can also take codeine or dihydrocodeine, a prescription of which can be provided to her at the time of the discharge. Remember, in the UK, we usually don't give them prescriptions for paracetamol and ibuprofen because it is freely available over the counter in all the supermarkets and drugstores and pharmacies. However, codeine and dihydrocodeine is available only through NHS hospital prescriptions, and hence that is the one prescription you may need to provide to the patient at the time of discharge. Ask the patient whether she will need a sick note or not. If she needs a sick note, that can also be provided. Following sterilization, the average duration of sick leave that we uh, suggest is between 1 to 2 weeks. Explain to her that is effective immediately after we do the surgery, and it is 99% effective in preventing pregnancy. So there's no need for long-term reliable contraception to be used after you get sterilized. Discuss the benefits, that's a permanent method. Discuss the risks of the surgery, risks of keyhole surgery, pain, infection, bleeding, risk of damage to abdominal organs, namely the ureter, bowel, blood vessels. In remote cases, there may be injury to the major blood vessels, which can get critical. There's a very, very remote chance of dying during the procedure. Also discuss or mention the risks that she might need a laparotomy if in case there are complications. Uh, Always discuss LARCs. It is a part of counseling for sterilization, and you will not score any marks if you don't mention. You have to discuss alternatives, which includes discussion of LARCs, which is the Mirena intrauterine system, the copper IUDs, and the implant, which is the Nexplanon device, which is colloquially called implant in the UK. Also discuss vasectomy, which is the permanent method of male sterilization. It's very important that you give very clear, evidence-based, correct information to the patient, yet your approach should be empathetic and supportive and help the patient make the right decision. Although the patient has come to you requesting sterilization, you're given her much more information which she might not be aware before, especially there are long-term reversible contraceptive options. There's an option for male sterilization, and she might feel confused at the end of your discussion and might want some more time to come to a decision. In that case, give her full support, offer her follow-up appointment, whereabouts she can come back and rediscuss the options. Summarize. In the end, if you have time, encourage that again, she has time to consider the option and there is no rush. Again, the tips for successful role play OSCE stations are saying you have to communicate well, you have to communicate clearly, but there has to be empathy and support in your approach to the patient, and you can achieve this using the tone of your voice, your body language, maintaining eye contact. Give them information, give them written information. There are leaflets which are available in every unit in the UK. Obviously, many a time, especially nowadays, we are going paperless. In that case, you can always post out a printed leaflet which is available in the Royal College website. regarding sterilization for more information. Summarize. So this is what we do in the end. These are the points that we go through, and it has become a kind of reflex to all the practicing gynecologists in the UK. So we say that we clip both the tubes. There's an option to get them removed. It's a permanent method of contraception. Obviously, it comes with a failure rate because there's no 100% in medicine. The failure rate is about 1 in 200. If you get pregnant after sterilization, there is a chance that it might be an ectopic pregnancy. Most failures happen in the first 1 to 2 years of sterilization. It is done as a keyhole surgery, as a day case under general anesthetic. If there are regrets in the future, fertility can be reversed using recanalization surgery or going through IVF, both of which will not be funded by the NHS and can be accessed privately by the patient. Discuss male sterilization briefly, that it is also a permanent method. It is highly effective because the failure rate is much better than female sterilization and quoted as 1 in 3,000. It's a much simpler procedure because it is done under local anesthetic. However, it takes about 3 months to become effective, during which time the patient and her partner will need to use a reliable contraception. Again, if there are regrets with the male sterilization, they have to go in the route of IVF and ICSI. Thank you.